mass, and there was no intracranial extension of the mass. So we made a clinical diagnosis of a T3N0M0 squamous cell carcinoma of the right temporal bone. So we proceeded to theater. We did a lateral temporal bone dissection, a parotidectomy, and selective neck dissection of the right side. The incision was a postauricular, and we did a postauricular and neck incision. We elevated the skin flap, and ear canal was resected with about 1.5 centimeter margin from the tumor. We sent the mass for a frozen section, and it was reported as being clear of tumor. Subsequently, the neck and parotid flap was elevated. We identified the facial nerve, and we did a superficial parotidectomy. In the parotid, there were small firm nodes. And we also proceeded to do a selective neck dissection of levels 2 and 3, and did a lateral temporal bone dissection. We did a cortical mastoidectomy, and we skeletonized the facial nerve. A posterior tympanotomy was done, which was extended inferiorly to the hypotympanum. The hammer and gouge was used to enter the middle ear, and the tympanic ring was separated. The temporalis fascia was used to obliterate the cavity, and the fascia was used to obliterate the eustachian tube. We achieved hemostasis and inserted a 1/4-inch drain in the scalp and the neck. The patient had a smooth postoperative course and was discharged after a week and was subsequently booked for radiotherapy. We got the histology. The first one showed a right lateral temporal bone dissection, moderately differentiated squamous cell carcinoma, and the level 2 and 3 nodes were negative for metastatic carcinoma. In the superficial parotid gland and the parotidectomy, there was moderately differentiated squamous cell carcinoma, as were the intraparotid nodes. So in terms of epidemiology, my discussion today is on temporal bone malignancies. So these are very rare tumors, and they are quite aggressive. The primary canal and middle ear cancers occur in about 1% per million people per year. Most are metastatic from the pinna and the external auditory canal. 1 in every 5,000 to 20,000 patients with an otologic complaint has cancer. And they account for about 0.2% of all head and neck cancers. That's how rare they are. And they have a preponderance to affect males in about the 6th and 7th decade, though we had a female patient. So in terms of the differential diagnosis of temporal bone tumors, you have to consider squamous cell carcinoma, and also basal cell carcinoma and other tumors like melanoma or chondrosarcoma or earwing sarcoma, verrucous carcinoma, adenoid cystic carcinoma, among others. You can also have metastatic disease, and the sites of metastasis are usually from the breast cancer, from the prostate, from the parotid itself, also from the kidneys, from the lungs, and also lymphoma. The presentation is mainly a classic triad. It's a classic triad of otorrhea, otalgia, and hearing loss. And this occurs in about 10% of patients. What is of note here is that otitis externa, otitis media, and cholesteatoma actually have these kind of presentations. They can present with any of those symptoms. So it is important that the clinician has a high index of suspicion if there is no response to standard therapy. In this series of 71 patients who had a confirmed squamous cell carcinoma of the temporal bone, there is a list of the symptoms which the patients presented with. As you can see, the top 3 out of the 71, the top 3 symptoms were otorrhea, otalgia, and hearing loss, accounting for almost 50% of the symptoms. In addition, there was also a facial nerve dysfunction in about 15%. There was trismus, an ear canal mass, itching of the ear, ulcer in the ear, and the tinnitus, vertigo, dysphagia, bleeding from the ear, a history of chronic otitis media, and also hoarseness, a tongue dysfunction due to hypoglossal nerve involvement, and also a neck mass. One has to do a thorough examination of the external ear, including the ear canals, the tympanic membrane, and the periauricular skin, and also the parotid gland and cervical lymph nodes, and the thorough cranial nerve exam And the cranial nerve function should be documented, because if the patient is going to go subsequently to theater, it's important to know what the facial nerve was before. And also, one has to test the first sensation on the affected site due to lower cranial nerve involvement. And a complete head and neck exam should be done. In terms of causes, it's difficult to categorize due to their rarity. However, ultraviolet light, genetic predisposition are known to cause skin cancer. And also, patients with chronic otitis media and cholesteatoma have been found to also have a squamous cell carcinoma of the temporal bone. HPV in miclia SCC has also been reported in literature, as well as radiotherapy. In terms of spread, from the external auditory canal, the tumor can spread anteriorly into the parotid and the temporomandibular joint. Posteriorly, it can spread to the mastoid and to the posterior, from the mastoid then to the posterior cranial fossa. Then medially, it can spread to the tympanic membrane and to the middle ear. Then from the middle ear, it can go upwards superiorly into the tegment tympani, the middle fossa dura, and the temporal lobe of the brain. Also from the middle ear, it can affect the facial nerve through invasion of the fallopian canal. It can also invade the carotid artery, the round and oval windows, and the eustachian tube. Then from the eustachian tube, the tumor can spread into the infratemporal fossa and into the neck. And then from the neck, it can spread into the jugular foramen. And in the jugular foramen, cranial nerves, that's where cranial nerves will be involved, especially cranial nerve 9, 10, and 12. And these patients will then present with dysphonia and dysphagia. Nodal spread is quite rare for T1 and T2 tumors. However, it occurs in about 10 to 20% of T3 and T4 tumors. And it usually spreads to the parotid gland nodes, preauricular nodes, the jugulodigastric, then to the jugulodigastric nodes and the deep cervical chain of lymph nodes. In terms of staging, the most popular one which is used is the modified Pittsburgh staging system. It's got a T, N, and M classification. And on the T classification, the T1 is the tumor that is limited to the external auditory canal without any bone erosion or evidence of soft tissue involvement. T2 is limited to the external auditory canal with bone erosion. It doesn't have, but not full thickness, or limited soft tissue involvement, which is less than half a centimeter. T3 is erosion through the osseous EAC, full thickness with limited soft tissue involvement, less than 0.5 centimeters, or tumor involvement in the middle ear and or mastoid. Then once you get to T4, then you've got erosion of the cochlear, extensive spread of the tumor involving the cochlea, the petrous apex, the medial wall of the middle ear, the carotid canal, the jugular foramen, or dura, with extensive soft tissue involvement of more than 0.5 centimeters. And also if there's any evidence of facial paralysis, that upgrades the tumor to a T4. In terms of N classification, this is not different from other tumors. The NO, there's no regional nodes involved. N1, single metastatic regional node less than 3 centimeters. N2A, single ipsilateral metastatic node 3 to 6 centimeters in size. N2B is multiple ipsilateral metastatic lymph nodes, and N2C, contralateral metastatic lymph node. And N3 is a metastatic lymph node which is more than 6 centimeters in size. In terms of the workup, it's important to do, apart from the bloods, which will be indicated as per a patient, your full blood count, your urine electrolytes, and so forth. Specifically for squamous cell carcinoma of the temporal bone, one has to do an audiogram as a baseline threshold for future comparison, and also for hearing rehabilitation as a result of the surgery, as we shall see later. Tissue biopsy is of paramount importance. Imaging, you can do a CT scan and MRI. A CT scan is to be high resolution with about 0.5 millimeter slices with or without contrast. One has to show the temporal bone, the brain, the parotid, and the neck. And this is essential for staging of the disease and for the soft tissue extent, and to find out if there's any bony erosion. In terms of the MRI, it's mainly for soft tissue involvement, especially if the external auditory canal and tympanic membrane are breached, and if there's any concern about the involvement of the dura or brain. Angiography and balloon, with or without balloon occlusion, can be done if there's any concern of a carotid artery involvement. So in terms of the treatment, it's a multidisciplinary team which involves the oncologist, the surgeon, the radiologist, speech therapists, and audiologists. Treatment can either be medical, which is radiation, chemotherapy, or surgical. And because of the rarity of these tumors, currently there's no consensus on a treatment. But the initial therapy, it's important that it should be radical and eliminate the disease, because positive margins tend to have a fatal results. Most recurrences are normal. You rarely get distant metastasis. So radiation therapy is ineffective for curative therapy according to the literature. Though literature is mixed on this, I was looking at some papers that said that case reports that say they've managed to cure the patient with radiation therapy. So there's no real agreement, but most of the literature says it's ineffective for curative therapy. It can be used with chemotherapy for palliation. However, the full course of post-operative radiation is indicated for stage T3 or T4 tumors. And it's been found that post-operative radiation actually improves survival in some studies. Chemotherapy is used as a neoadjuvant and adjuvant therapy. It can be used alone for palliation. However, there is no evidence that it improves survival or local control. So surgical therapy, this is the bona fide treatment of temporal bone malignancies. It can be divided into two, which is the definitive procedure and adjunctive procedures. So in terms of a definitive procedure, the first one is a sleeve resection. I'll go through this. Sleeve resection, lateral temporal bone resection, extended temporal bone resection, and total temporal bone resection. And adjunctive procedures, depending on the extent of the tumor. One can do a parotidectomy, a craniotomy, or selective neck dissection. So sleeve resection, also known as local canal resection, is removal of the bony ear canal skin and reconstruction with a split thickness skin graft. So the problem with this procedure is that you don't get clear margins. Like if you're going to excise the skin over the bone, you don't get clear margins, and it can only be done if the whole tumor is within the cartilaginous portion of the external auditory canal. As a result, it is no longer popular. Most people are no longer doing it. The advantage of it is that there is preservation of hearing. And as I've said, it's not an oncologically sound procedure, and it's linked to high recurrence rates. Lateral temporal bone resection, this is the main surgical procedure that is done for these tumors. It involves unblock removal of the ear canal lateral to the facial nerve and the stapes. In other words, it's removal of the external auditory canal, the tympanic membrane, the malleus, and the incus, with preservation of the otic capsule and the facial nerve. It's the approach is a post-auricular and meatal incisions, and a cortical mastectomy is done. And one can include parts of the pinna and tragus for excision. In addition, a parotidectomy or neck dissection or mandibular condylectomy is done depending on the extent of the tumor. So a blow-by-blow account of how this procedure is done, I'll refer you to the open atlas of otolaryngology head and neck operative surgery on the lateral temporal bone. This is a free resource, as we all know, available on the internet. There are quite good pictures and quite detailed procedures on how to do it. Extended temporal bone resection, I've seen it also being referred to as subtotal temporal bone resection. This is done for disease extending into the middle ear and mastoid. It is actually a lateral temporal bone resection with additional dissection of the medial bony wall of the middle ear, with an extended mastoidectomy and removal of the otic capsule. This can be unblock removal or piecemeal removal. The piecemeal removal is usually done to try to avoid complications. Because you're removing an otic capsule, this sacrifices hearing, but mainly sensorineural hearing. The dissection may include the condyle of the mandible, the facial nerve, the dura and the brain, the infratemporal fossa contents, and the sigmoid sinus, depending on the extent of the tumor, so the tumor will guide you. The total temporal bone resection is actually an extended temporal bone resection, which includes the petrous apex and internal auditory canal. if an arm block resection is done, one has to sacrifice the internal carotid artery, the cranial nerves 6 to 12, and the surrounding structures. However, if these are preserved, one will have to do a piecemeal resection if they want to preserve any of these structures. However, it is associated with a significant morbidity and may not significantly improve survival. And because of significant morbidity associated with this, very few people actually do it, the temporal bone resection. Management of the neck is controversial. It's quite useful for disease staging. Like our patient, we did the neck dissection and the histology showed that there was no lymph node, there were no lymph nodes involved in the neck. It's quite useful for disease staging, as I've said, and it allows access to vessels for free flaps. It's been shown that neck dissection in a positive, with positive nodes in an N-positive neck does not improve overall survival. The levels that are usually dissected out are levels 2 and 3, but I've seen papers where some people in their case reports, they're saying they went on to dissect level 5A and so forth, but it's all out there in the literature. It's because there is no consensus on this because of the rarity of these tumors. But in terms of the practical application of the staging system, I got this from the Vula Atlas. For a T1 tumor, one can do a sleeve resection or lateral temporal bone resection. For T2, it's a lateral temporal bone resection. And T3 may be suited to lateral temporal bone resection with the sacrifice of the facial nerve. And then T4 is not amenable to lateral temporal bone resection. Complications, as we have seen, this is extensive surgery. It depends on the extent of the resection. Hearing loss, which can be conductive or sensorineural, vertigo, facial nerve palsy, and other cranial nerve deficits, CSF leaks, meningitis, intracranial bleeds, and trauma and resection of the carotid artery. So after having done the surgery, one can do a reconstruction with either the anterolateral thigh flap or radial forearm flap or pedicle to myocutaneous flaps or scalp transposition fasciocutaneous flap, and also facial pulse work, which can be static or dynamic procedures. Also, if the pinna is resected, one would consider offering the patient a prosthesis. Thank you very much.
Great. Thank you very, very much, Raphael, for indeed a complicated case. I'd like to perhaps get comments from Dr. Tashneem Harris, who's our local otologist and lateral skull-base surgeon and one of the authors of that chapter that you projected. Dr. Harris? I see Dr. Harris may have left briefly, but that's fine. Perhaps comments from the editor of the Open Access, Professor Fagan. Any comments from your side?
Well, thank you very much. I thought there was a very comprehensive presentation. I think just a few points, just terminology. Raphael, you mentioned that one of the causes of these tumors is a metastasis from the parotid, but it's an extension. It's not a parotid. It's not a metastasis. So just in terms of terminology, really, I think one of the issues around these tumors is that if you don't control them, these patients really die a horrible death, because once you get involvement of the skull base and especially of the dura, then they have extreme pain. And so really, I think there are two issues here. Firstly, you want to select your patients that you're going to operate on carefully and not offer them surgery if the chances of cure are really poor because of the mobility of the surgery. But secondly, if you're going to operate on them, then we do generally offer them post-op radiotherapy because you want to get the very best chance of cure. And so so the Pittsburgh classification really speaks to being very cautious about offering patients surgery once you get involvement of the medial aspect of the middle ear cavity, because if I recall correctly, that was really based on a study where they found that once you have involvement of the promontory and the medial aspect of the middle ear, that that the benefits of aggressive treatment are really quite limited. So in my hands, I've always been very careful to try and establish whether the tumor has extended medial to the tympanic membrane, and once it involves the promontory, then one has to be very cautious about offering them any form of surgery. And I was interested by that comment you made, that the benefits of operating on a patient with an N-positive neck are quite limited. Doing a neck resection, it doesn't increase or doesn't improve the outcomes. And I suspect that probably refers to the fact that those patients probably had very, very advanced local disease, and they probably died from a local disease. So once again, that probably speaks to selecting your patients properly and not offering patients aggressive surgery when the chances of improving their outcome is really limited. Tasneem Harris is scrubbed in theatre at the moment with a laryngectomy, but she said she would speak on her cell phone, so maybe you can retry her for her comments.
Sure. Thanks very much, Professor Fagan, for your valuable comments. Dr. Tasneem Harris, I see still maybe busy in theatre. She hasn't joined just yet. Perhaps any comments from Dr. Kenneth Baidu from Ghana, West Africa?
Good morning. Thank you, Raphael, for an elaborate talk. From our end, if I cast my mind back, I may have just seen one patient who may have had more like a SCC of the temporal bone, but the patient came to us in such an advanced disease state that we practically didn't do much. We just controlled the symptoms and then treated her palliatively. So not much on the ground of experience to share, but I think it's still a rare disease in our ends, yeah. Or they don't really come to see us because they always find it quite in such an advanced state. Thank you.
Thank you very much, Dr. Baidu. I see Professor Hill, who's a pathologist as well, is on the call. Professor Hill, any comments from your side, perhaps also commenting on the difficulties sometimes of getting a representative sample from the external auditory canal in these kind of cases?
Yes, good morning, everybody. Yeah, absolutely. Obviously, the diagnosis primary diagnosis very much depends on a representative biopsy. So what I always would suggest is to not biopsy in an ulcerated area if you can actually see some either distinct tumor tissue or just away from an ulcer into the mass. And I think that would be the best option. I think that squamous cell carcinoma is not difficult to diagnose if you have a few cubic millimeters of tissue. What I would like to actually add to this conversation is the interesting thing of the diagnosis of squamous cell carcinoma of the parotid. So it's been now shown that the diagnosis of squamous cell carcinoma of the parotid is extremely rare, and that most of the diagnoses of this condition are actually metastases from the skin, and in this particular case, from the auditory canal. So that's very important to realize that if you do have a diagnosis of a squamous cell carcinoma of the parotid, is to look for the primary in the region on the skin, and obviously where you just diagnosed the case from.
Great, thank you very much, Professor Hill. That's a very important comment. Thank you very, very much. In view of time, I think we'll move on to our second presentation. And if Dr. Harris joins us Perhaps during that presentation, we may give an opportunity to comment on this case. But Raphael, thank you very much again for your presentation. Our second presentation is from Dr. Matthew White, who's a resident at the University of Cape Town. Matthew, thank you for presenting your case. Please go ahead and you can share your screen.
Thank you very much, Cecile. Can you see my slides?
Yes, we can.
Okay, great. So again, good morning, everyone. My name is Matthew White, and I'm a registrar here at the University of Cape Town. And I'd just like to thank everyone for the opportunity to present to you this morning. Just a brief disclaimer, I've written consent from the patients to publicly share their clinical details on this platform, and all my content is referenced. So to start with the case of Mr. H, he was a 65-year-old male, hypertensive, who presented with a 7-month history of progressive dysphonia with no adenodysphagia, no symptoms suggestive of aspiration, no associated weight loss, hemoptysis, or autolgia. In terms of his risk factors for squamous cell carcinoma, he had a significant background as an ex-smoker in excess of 30 pack years with synchronous alcohol use. He had a good performance status at ECOG-1, also with a reasonable effort tolerance, New York Heart Association class 1. Socially, he was retired, living alone with his wife, and was a non-professional voice user. Clinically, he was an elderly male. He was notably dysphonic with a hoarse, rough voice, with no audible stridor or respiratory distress. On examination of his neck, he had no palpable lymphadenopathy, no normal laryngeal cartilage skeleton, and on auscultation, his respiratory system was essentially clear. Flexible nasal endoscopy was done, which revealed a small exophytic tumor limited to the anterior third of the left true chord with extension to the anterior commissure. His bilateral vocal cords were mobile and symmetrical, and he was provisionally diagnosed with a suspected clinically T1A N0M0 glottic lesion. Chest x-ray was done, which showed clear hyperinflated lung fields with no evidence of metastatic disease. He was subsequently booked for a pan endoscopy where rigid laryngoscopy and esophagoscopy was done, which again was in keeping with the flexible endoscopic findings. The biopsy subsequently revealed an infiltrating, well-differentiated keratinizing squamous cell carcinoma. At our subsequent MDT tumor board at early 32, together with the oncologists and the speech therapist, the patient was counseled and chose to have surgery. He subsequently went to theatre and had essentially a type 5A chordectomy, which included resection of the left anterior 2/3 of the left vocal cord, anterior commissure, and a segment of the contralateral anterior true chord. The following day, he was eating well with minimal pain, mild dysphonia, and no stridor, and was discharged home. So despite this being a relatively straightforward case, I've chosen to present it to discuss the significance of anterior commissure involvement in early glottic carcinoma, and attempt to discuss the controversies which surround it, and in doing so, address the following questions. Firstly, where is the anterior commissure and how does one anatomically define it? Does it require any special investigations? Does it pose any specific surgical challenges? And what is its prognostic significance in terms of oncological and voice outcomes? And finally, should it better be reflected in the future TNM staging systems? So just before we move on to the specific controversies regarding the anterior commissure, I just want to clarify a few key points, which I'm sure we're all aware of in terms of the general principles of management of early glottic carcinoma. Firstly, we are all specifically referring to localized or early disease, AJCC T1 or T2 N0 stage disease, or stage 1 or 2 disease. And I think we'll all agree that whichever management option is chosen, these patients should ideally be managed and counseled in the context of a multidisciplinary team, as we did, involving the minimum of a head and neck surgeon, an oncologist, speech and language therapist, possibly a dietitian, and sometimes where possible other disciplines such as a radiologist, pulmonology, and a social worker may contribute. It's well established in the treatment of early glottic carcinoma that the aim in treatment is laryngeal conservation through a single modality treatment which preserves laryngeal function whilst at the same time offers an excellent chance of cure. Specifically, when we refer to laryngeal function, we're referring to function of voice and open airway independent of a tracheostomy and swallowing without significant aspiration. The literature recognizes that both transoral laser microsurgery or primary radiotherapy can achieve this goal. And historically, open partial laryngectomy procedures such as laryngofiscal chordectomy or vertical partial laryngectomies were considered acceptable and may still be acceptable in a resource-constrained environment. In terms of the management of the neck, the rate of occult nodal disease is extremely low at less than 7%, and therefore no elective neck dissection or radiotherapy is required in N0 disease. In terms of comparing our two main modalities, radiotherapy and transoral laser microsurgery, this is controversial in itself with multiple nuances in the literature in support of each modality. Broadly speaking, the prognosis in terms of local, regional control and disease-specific survival are relatively comparable at an excess of 95% for T1 disease and an excess of 80% for T2 disease, with some literature showing a lower rate of laryngeal preservation with radiotherapy, with generally comparable voice outcomes. Basically speaking, transoral laser microsurgery offers the following advantages. It's cost effective to both the patient and the institution. This has been illustrated in cost utility studies. It is practical as day case surgery with expedited recovery, short hospital stay, a low side effect profile. And these aspects are also reflected in studies such as the Easter trial. It is further supported by multiple studies which have shown that in up to 20 to 30% of biopsies, these are essentially curative in early disease, where subsequent resection or biopsy has revealed no residual invasive malignancy. It facilitates accurate pathological staging, and in the event of local recurrence, one has a repertoire of options including repeat laser resection, again, open partial laryngectomy or radiotherapy. Acknowledged disadvantages include the initial cost of the equipment, the surgical learning curve, the need for general anesthesia, and possible difficult access. The patient may also require reasonable pulmonary reserve. This is obviously more important for more advanced resections, where patients may have to tolerate a temporary or even permanent degree of aspiration. Broad advantages in terms of radiotherapy include the avoidance of general anesthesia, which is of benefit in high-risk patients or in cases of poor oral access. It possibly has better voice outcomes with the involvement with lesions of the anterior cord or anterior commissure. Disadvantages include that it obviously includes 6 weeks of therapy. It has long-lasting acute and long-lasting side effects ranging from mucositis, dysphagia, xerostomia to chondroradionecrosis. And as I mentioned, in cases of treatment failure, salvage is challenging and inevitably results in salvage laryngectomy in most cases. There's also a recognized risk of radiation-associated malignancy. Open partial laryngectomy, as I mentioned, involves a laryngofiscal chordectomy or vertical partial laryngectomy or rarely a suprachicoid laryngectomy. These procedures offer an excellent oncological outcome in terms of survival and local control. However, they are rarely performed due to them being associated with a less predictable and logically a poorer functional outcome in terms of phonations and swallowing and tracheostomy independence. So if we move on to the anatomy of the anterior commissure, according to the TNM, it's a subsite of the glottis, but there's no universally agreed upon anatomical definition. And even the 8th edition does not define its exact boundaries. And I must say, the more I read about its anatomical descriptions, the more confused I became. Practically speaking, the anterior commissure can be considered as a clinical concept used to describe the anterior part of the glottis, measuring approximately 1 millimeter in width by 10 millimeters in length, where the true vocal cord ligaments converge anteriorly as a fibrous band or tendon known as Broyles tendon, and it inserts onto the inner aspect of the thyroid cartilage. It's further considered to be in continuity or in at least close proximity to the insertion of the thyroepiglottic ligament. So similarly, its role in facilitating or resisting tumor spread is a subject of debate. The anterior commissure tendon itself is intrinsically resistant to tumor spread due to its fibrous and avascular nature, resulting in a low incidence of approximately less than 20% of glottic tumors originating in the anterior commissure. However, it may represent an anatomically weak point, facilitating early cartilage invasion. This has been hypothesized to be due to several factors. Firstly, the thyroid cartilage is devoid of its resistant inner perichondrium at its insertion point. In addition, at its insertion, the mucosa of the vocal ligaments and at the insertion of the tendon is in closer proximity to the thyroid cartilage than anywhere else. Logically, if you think about it, at every other laryngeal subsite, there's either a muscle or a paraglottic space or perichondrium between the laryngeal cartilage and the surface mucosa. Thirdly, a local inflammatory response has been recognized in early tumors to occur in close proximity to the anterior commissure tendon, which results in ossification of the thyroid cartilage, which further facilitates tumor invasion. Its close proximity to the thyroepiglottic ligament and epiglottic petiole facilitate early spread into the preepiglottic space, which is of course in continuity laterally with the paraglottic space. Further, its close proximity inferiorly to the cricothyroid membrane allows for potentially early extralaryngeal spread via the cricothyroid membrane. So if we look at the role of imaging in anterior commissure glottic carcinoma, now knowing the patterns of spread and invasion, it makes sense that much of the concerns regarding imaging are directed at early detection of invasion of the thyroid cartilage, the preepiglottic space, paraglottic space, and prelaryngeal soft tissues. These features will obviously upstage the patients to T3 or T4 disease depending on the degree of invasion. In our unit here at Pittsburgh, we do not routinely image our patients with clinically early glottic carcinoma involving the anterior commissure, but adopt the philosophy of Steiner and Ambrosch, where we follow the disease during the resection as required. However, keeping this in mind that this is under the guidance of Professor Fagan, an extremely experienced laser surgeon, and therefore if you are a less experienced laser surgeon, imaging may be beneficial in knowing what you're getting yourself into. And it may further play a role in patient counseling and prognostication. Here in our unit, we are more likely to perform imaging in a patient with anterior commissure involvement who is considering radiotherapy first line, where if extensive cartilage involvement is found on imaging, we would counsel the patient on the risk of chondroradionecrosis and a potentially poorer oncological outcome should they still wish to proceed with radiotherapy. If we compare the modalities in terms of imaging, most studies compare CT to MRI. And in a meta-analysis and systematic review, MRI was found to have a superior sensitivity in detection of cartilage invasion at 88% compared to CT scan at 66%. Both modalities were comparable in terms of specificity at 88% and 81% respectively. Other advantages of MRI include its excellent negative predictive value in detection of cartilage invasion, and its superiority in assessment of the pre-epiglottic space, the paraglottic space, base of tongue, subglottic, and soft tissue involvement. Disadvantages include its high cost, its slow acquisition time, inherently long waiting lists in hospitals, and its poor dual assessment of metastases. Ultrasound is an often forgotten imaging modality with few studies assessing its utility in laryngeal carcinoma. In one of the few studies I came across, it illustrated an excellent accuracy at detecting cartilage invasion at 88%, which was in fact superior to MRI at 85%. Other obvious benefits include that it is cheap, it does not require contrast, and it's generally more readily available. Just as a final comment on imaging, I'd like to emphasize that all the studies regarding these imaging modalities are done in academic centers of excellence and may not reflect the capabilities of your local radiologist. Therefore, your results are only as good as your own ability or your local radiologist's ability to interpret these investigations, and your choice of imaging should be tailored appropriately. So if we look at the impact of the anterior commissure on the practical aspects of surgery, I think we will all agree that it is a challenging area to visualize and work on. This can be predicted by a shortened hyoid mental distance and made worse by the usual factors associated with poor visualization, including a reduced interincisor gap, poor dental status, macroglossia, micrognathia, limited neck mobility, a history of previous neck surgery or radiotherapy, advanced Mallampati scores, and higher BMIs. Techniques described to improve visualization and access to the anterior commissure include removal of the shoulder roll and moving the patient from extension into the so-called Boyce-Jackson or sniffing position with the neck slightly flexed, thus straightening the C-spine and potentially improving visualization. Cricoid pressure can help, either provided directly by an assistant or by downward pressure applied by strapping or anchored to the bed. The use of specialized anterior commissure scopes of various types is described, which generally have a more acute angle or a triangular shape. Alternatively, descending laryngoscopes like the Steiner or Weirder diverticular are described. And alternatively, the microscope can be substituted for angled endoscopes, 0, 30, 70 degrees, combined with a handheld flexible laser diode fiber. And newer studies are exploring the role of transoral robotic surgery in early glottic tumors. And ultimately, if you can't oncologically safely resect the disease, one should admit defeat, wake the patient up, and consider radiotherapy or referral to a more experienced laser surgeon rather than attempting to resect unsafely. Once the anterior commissure is adequately visualized, one can proceed with resection. However, as I mentioned earlier, these are challenging cases for the experienced laser surgeon. Patients often require a minimum of a type 5A cordectomy, sometimes a type 6, with excision of the vocal ligament, the anterior commissure, and anterior contralateral cord. As I mentioned before, our approach to the anterior commissure is based on that of the work pioneered by Steiner and later Ambrosch, where excision is planned as in the top right image from the Vula UCT chapter on CO2 laser microsurgery, where once the vocal ligaments are excised, the tumor is stripped in a plane deep to the perichondrium, where if no further erosion is identified, the tumor bed can be sterilized by defocusing the laser, as in the bottom right imaging. However, if there's deep cartilage invasion following stripping of the pericondyrium, the tumor can be chased and may even require full thickness excision of the cartilage, even up to just deep to the skin. And alternatively, it can be combined with an open laryngofiscial excision. The use of frozen section is described. However, we do not use frozen section routinely here in our practice. Webbing of the anterior true cords is a well-described complication of resection involving the anterior commissure, especially in T1B disease involving both cords. Laryngeal webs are generally associated with a poor outcome in terms of voice, and when severe may cause upper airway obstruction. In many cases, it's unavoidable. However, some surgeons will stage the resection, initially resecting one side and returning 1 month later to resect the contralateral side. Once established, the web cannot merely be divided as the rate of refusion is unacceptably high. Techniques used include temporary lateralization with a suture or the use of a temporary keel, with some surgeons applying topical mitomycin as an adjunct. Traditionally expensive preformed silicone stents costing in excess of $250 US or keels fashioned from equally expensive silastic sheeting are used. However, in a study conducted in our unit by Dr. Maguire and Professor Fagan, they demonstrated that a keel fashioned from inexpensive brown general merchandise tape was safe and equally effective. If we look at the overall impact of the anterior commissure involvement on laser surgery, in a retrospective review by Dr. Stevenson and Professor Fagan, a study was conducted to assess the significance of anterior commissure involvement on outcomes in laser microsurgery. The study included 76 patients managed by a single surgeon with disease ranging from carcinoma in situ to T3. 30 of the patients had anterior commissure involvement. The results of the study revealed that anterior commissure involvement was associated with an increased rate of uncertain or positive margins at 63 versus 30%, and that patients with anterior commissure involvement were more likely to receive radiotherapy at 40% versus 3%. However, both groups had excellent comparable rates of laryngeal preservation at 96%. On the basis of these findings, it was concluded that laser resection with the use of adjuvant radiotherapy in patients with adverse pathological findings can be recommended for the treatment of early glottic carcinoma with anterior commissure involvement with excellent local control and laryngeal preservation rates. So based on the challenges illustrated in the previous slides in terms of surgery, should we rather than just submit patients with anterior commissure involvement to radiotherapy? This again is a point of controversy, with several publications suggesting that the anterior commissure is associated with a poorer response to radiotherapy. A meta-analysis of the local control rate of early stage laryngeal carcinoma managed with radiotherapy revealed inferior control rates with involvement of the anterior commissure at between 55 to 80% versus 82 to 90% in early disease where the anterior commissure was not involved. However, having said this, other studies have provided conflicting data indicating that anterior commissure involvement is not necessarily associated with poor local control rates. Reasons postulated for possibly poorer oncological outcomes include, firstly, the potential for an increased occult or missed cartilage invasion, or a clinical understaging rate which may be as high as 40%. And there's further reported risk of underdosage at the air tissue interface due to the superficial proximity of the anterior commissure, leading to poorer coverage of the prescribed dose, with some oncologists advocating for an increased dose by a factor of 2 gray for this subsite. Broadly speaking, in terms of voice outcomes in early glottic carcinoma with anterior commissure involvement, must be emphasized that despite voice being an important aspect, it should obviously not be prioritized above oncological outcomes. Multiple meta-analyses and systematic reviews have been done to directly compare outcomes between radiotherapy and laser in early glottic carcinoma, with most studies supporting that for small mid-chord lesions requiring a type 3 chordectomy or less, long-term measures of voice are comparable, definitely by 1 to 2 years. However, no studies have directly compared these modalities in terms of anterior commissure involvement. However, it's logical that involvement of the anterior vocal ligaments and anterior commissure would result in inferior voice outcomes, especially where large resections are required. In one study I found by Peretti and colleagues looking at the voice outcomes following type 5 chordectomies, which is the usual minimum surgical requirement for anterior commissure involvement. At 2 years, the majority of patients were found to have 82% were found at 2 years to have a subjectively mild dysphonia, with less than 20% having a moderate degree of subjective dysphonia. The last study I'd just like to end with is the following study published in the Laryngoscope in 2019 by Tooley et al., which through systematic review and meta-analysis assessed the prognostic value of anterior commissure involvement in T1 glottic carcinoma. 16 studies and a total of 4,341 patients were included. 84% of patients were treated with RT and 16% with laser. The study confirmed that anterior commissure involvement is a negative prognostic factor in local control at 5 years, associated with 12% overall reduction in local control, and specifically a 23% reduction in T1A disease and a 13% in T1B disease. On this basis, the authors of the study suggest that the AJC should reflect the anterior commissure better regarding its negative prognostic impact in its T staging. This sentiment is reiterated in other similar studies. So in conclusion, watch the space, as it still remains a point of considerable controversy and may be taken into account in future staging systems. However, having said this, despite all its hype, it's only one of multiple factors which may or may not influence your choice of treatment. And again, just to re-emphasize that all decisions should be individualized in the context of the MDT, taking into account the usual patient, tumor, or disease and institutional factors. These are my references. Thanks, Tasia.
Great, thank you very much, Matthew. That was very, very comprehensive and raised a lot of controversies that you have very eloquently pointed out. I'd like to, just ask Professor Fagan perhaps to begin the comments. Professor Fagan, any comments from your side, especially with the study that you and Kate Stevenson had authored in 2017?
Yeah, I'd like to congratulate Matthew with that presentation. It really was very comprehensive and the best presentation I've heard on the topic. So well done. Just to qualify the issue around imaging, we don't image early tumors. So if it's a T1B tumor, it's a small volume tumor, then certainly I don't think imaging has much of a role, because you're going to expose that area by stripping the stripping the perichondrium off the cartilage, and you can inspect it very, very well. And as you mentioned, the Wolfgang Steiner says you must simply follow the cancer. So if you see some erosion of the cartilage, you simply excise that cartilage. But certainly for the larger tumors situated at the anterior commissure, I think imaging is very important, because you'd like to, because some patients that you might not offer laser treatment to, or radiotherapy for that matter. You did allude to the issue about access, and there are some patients where you simply can't get access to resect them endoscopically. You always have to advise the patients, if you're going to be doing any surgery, that they're going to end up with a poor voice, and that might steer a patient who's very dependent on their voice quality, the teachers, etc., towards radiotherapy. One has to give them that option. But essentially, one has to adopt a staged approach. For the very small or the smaller tumors, it's going to be CO2 laser or it's going to be radiotherapy. And then in the larger tumors, if they're favorable following images, you can offer them a supracricolaryngectomy or a vertical partial laryngectomy. And then the larger ones, you have to do a total laryngectomy. And also just a bit of history, that when I was training in ENT, which is not that long ago, the quality of the CT images was not that good, and it was standard in our unit under the previous head that for even a T1 tumor extending to the anterior commissure, that patients routinely had a total laryngectomy done, and that was due to the concerns of cartilage invasion. But really, I thought that was an excellent presentation. Thank you very much.
Thank you very much, Professor Fagan, for your comments. It would be nice to hear from different parts of the continent as well on such a controversial topic. And I'd invite anyone from around the region to perhaps comment. I see Dr. Chege Macharia is also on, who's a consultant at the Kijabe Hospital in Kenya. Any comments on what your unit does or what your take was on this case?
Thanks, Tasir. No, that was an excellent presentation, and no, I don't think I'd have much to add on that, but that was really well covered. We don't see too many of the early stage diseases, so probably what I'd comment is just two things which I find really applicable, especially in resource-constrained settings. I think the use of ultrasound that has come out real strong there. Even in this COVID-19 times, where one can use an ultrasound just to get a fairly good idea, imaging and depth of invasion of early glottic cancers. And then also, again, something we've talked about before concerning the open approach in the absence of, laser therapy to some of these early cancers. I think that has come out really, really well, and that was an excellent presentation. Thanks.
Thanks, Dr. Macharia. Any comments from Bloemfontein? Professor Riaz Sidat, any comments from your side?
I think it was an excellent presentation that Matthew did. We also see very few early stage larynx carcinomas. But I think the utility of the ultrasound sounds quite useful in assessing cartilage invasion. Again, it's very operator independent, so it really depends on the radiologist who's performing it to see whether it's superior to CT or MRI.
Thank you very much, Professor Sidat. Professor Fagan, any comments on the use of ultrasound?
This is something that Professor Mary Sebelik, who ran the ultrasound course on the head and neck for us, she's from Atlanta, from Emory University, and she was promoting the use of ultrasound for looking at larynx pathology. And I think it's probably something we should encourage our radiologists to acquire some expertise in, or otherwise, if the ENTs themselves have access to ultrasound, that they should do so. And I know that Shazia Peer has established a prospective study looking at ultrasound use for assessing some neonates and young children with upper airway pathology.
Thank you very much, Professor Fagan. And I see Professor Hill has also raised his hand. Prof. Hill, please go on.
Yes, good morning, everybody. I rather have a question. First question, was this tumor removed in sections by laser, according to the Steiner and Ambrose method? I presume
yes,
it was.
Yes, Prof, was removed in piecemeal.
So, all right. So my question is to all the participants, is that how much do you rely on the accuracy of the pathological examination of the margins in these specimens?
Maybe I can comment there. You know, so it is a mix of your clinical impression as well as the pathology report. It can sometimes be difficult to orientate these patients or these specimens very carefully. But if you're dealing with a mid-cord tumor, which is 1 millimeter in size, you know, I manage them like a small skin cancer. As long as you can monitor the patient carefully, even if the margin is a fraction of a millimeter, you know, then I would just watch those. But if it's at the anterior commissure, then clearly if they do recur, then it's a different story altogether. And so those are the ones where we'd be more prone to giving them post-op radiotherapy if there's a concern about margins.
Okay.
Tasia, can I perhaps ask a question?
Sure.
Professor Fagan or anyone else who'd like to comment, I did see some the presentation got a bit long, but I did see some more recent studies are looking at the role of kind of ablation in terms of photoangiolytic laser therapy. Do you feel that that's oncologically an acceptable means of therapy for kind of small low bulk T1 disease?
I've got no idea. I haven't followed that. I haven't followed that conversation or that development.
Great. If you have any last final questions, please post them on the chat line or raise your hand. But otherwise, in the view of time, I'm gonna close. Matthew, any closing comments from your side before I close?
No, thank you very much, Tasia.
Okay, great. I see there are a couple of comments on the chat line on how we can get recordings, on how the audience can get recordings of some of our sessions. I've just posted the link to our YouTube channel that has some past select sessions that we've had on this platform. And sessions like these will be uploaded in the next few days. And I'd urge you to just have a look at the link and the channel. We have over 200 subscribers now. Please subscribe to it, share it, and feel free to post any comments or likes on that channel as well. But otherwise, thank you once again for everyone who has joined us. Thank you to our presenters, to two excellent presentations once again, and to everyone that has commented or taken that time to ask questions and to really attend. But otherwise, we'll see you. I see there's one last question here. Sorry, just as I was finishing. This Dr. Satya Chaudhary has asked, can the vocal cord be visible at all with regular ultrasound NECs? I think from her experience, she's saying that she can't really see it very clearly using the ultrasound, if I gather correctly from that question. Matthew, do you want to comment on that, on the study that you talked about?
Yeah, sure. So I mean, the main role from what in terms of the utility or benefit of ultrasound is specifically in terms of assessing for cartilage invasion, which is what that study looked at. In terms of looking at other parameters in terms of staging laryngeal tumors, it's obviously significantly poorer compared to other modalities like MRI. As far as I'm aware, ultrasound is definitely able to assess the vocal cord to a certain extent, and is sometimes even used to diagnose a vocal cord palsy. But I don't think it accurately will be able to describe or delineate any pathology of the true cord or false cords itself.
Okay, great. Thanks very much. I'm sure that answered your question, Dr. Chaudhary. I see I'm just going to allow one more comment. Sorry, Matt, you're not off the hook just yet. There's one more raised hand, and I think we're going to end it there just in view of time. There's Dr. Ibrahim that has raised his hand. Please go ahead.
Hi, guys. Thanks for a brilliant talk. just a comment to the head team at UCT. You guys mentioned that with your study looking at anterior commissure lesions, there was a 40% increased need for radiotherapy in your findings. And then your conclusion is that at the end that you guys mentioned that you recommend surgery and radiotherapy for anterior commissure lesions. My question is, in view of trying to achieve single modality treatment for most cancers, wouldn't you then just recommend radiotherapy as your first treatment modality, knowing the risk that the anterior commissure poses? The second point, just as a comment, just what we do in New Zealand, and you know, with anterior commissure, there's always a risk of the cartilage invasion. I think the ethos of Steiner and his abilities, and it seems, and of course, Professor Fagan's ability, not many surgeons can achieve that, you know, chasing the tumor through the cartilage. And I think if you don't have that experience or ability, it's probably worthwhile not embarking on that upfront and having the CT scan in the beginning to avoid an unnecessary theater list being wasted and referring that patient to radiotherapy, especially speaking from a resource limiting center like in Africa. So just a comment there about that.
Great, thank you very much, Dr. Ibrahim, for those comments. I see Professor Fagan has left the call, but Matthew, any replies to that comment, particularly to that study that you talked about?
Thanks, Dr. Ibrahim. Yeah, it's unfortunate that Prof's left. I didn't feel entirely comfortable commenting on the utility of his study, but that is obviously one of the drawbacks which I did fail to mention in terms of chasing the anterior commissure in laser surgery. So, I mean, as I did open with, you are obviously correct that in early glottic carcinoma, one should ideally aim for single modality treatment. And where adjuvant radiotherapy is required, you have possibly failed to achieve that. So likewise, you know, in early anterior commissure involvement, you also, where you've now done imaging, you're subsequently going to upstage your tumors quite often to T3 or T4 disease, which often raises further questions now. Are you obligated to address the neck either with radiotherapy or surgically? So I don't think I answered your question, but you'll have to maybe I'll ask Professor Fagan later today, and I'll get back to you.
Let us hear. Let us hear.
Yes, Dr. Mainasaro.
Yeah. In African countries, like in Nigeria, we have problem with radiotherapy because of the waiting time accessibility. So in my center, I use direct laser with endoscope to excise anterior glottic lesion in early laryngeal cancer. Well, I assess the patient clinically with endoscope in the clinic. I don't do CT scan for early glottic cancer because of the cost, and also the once it's an early glottic cancer, I know that there is no cartilage invasion. So I use endoscope instead of microscope, and I use different types of probes with the angle tip so that I can actually assess the anterior commissure with angle scope. So with angle scopes, you can actually excise all lesions in the anterior commissure compared to the microscope. Thank you very much.
Excellent, that's great to hear. And Dr. Mainasaro, does your unit also have a translaser oral microsurgery as well, the ones that Matthew were talking about? And secondly, any comments on open partial laryngectomies as well that your unit might do for those cases?
No, we don't have a CO2 laser. I use direct laser with fiber. So with fiber, you can actually manipulate the tip of your probe to assess the anterior commissure compared to just the CO2 laser. So Professor Fagan has a very good experience in terms of exposure to the anterior commissure. I've assisted him in various surgeries, trying to remove lesion in the anterior commissure. But with CO2, with diode laser and angle scope, I have a special video laryngoscope whereby you can introduce your scope. You don't need to hold it. So you have your two hands to use your instrument and suction instead of using one hand to hold the endoscope and one hand to do the surgery. So it's actually very handy, and diode laser is not bulky as the CO2 laser.
Yes, yes. That sounds very interesting, Dr. Mainasara. What I would urge you is if maybe one of your trainees can get in touch with me or one of us at UCT, and perhaps you can have a case presentation on the same and how you've devised your configuration to handle such a case. So please, I'd urge you if one of your trainees can feel free to get in touch with one of us, and they're free to present that on this platform as well.
Okay, thank you, Tasir. We'll do that.
Thank you, Dr.
Thank you. Thank you.
I think in view of time, I think we've had a very healthy discussion. I'd like to end it here. I think discussions on the anterior commissure can probably continue for the rest of the day. But thank you once again, Matthew, for an excellent presentation. And thank you for everyone that has joined us. I wish you all a lovely weekend ahead. We have an interesting presentation next week, Wednesday, from a maxillofacial surgeon. So it'd be nice to hear and invite you for that presentation as well next week, Wednesday. Take care and all the best.